Welcome to MedSimu Surgery Podcast. Today, we're doing a deep dive into something absolutely fundamental in surgical practice, fluid balance and fluid replacement therapy.
Absolutely. It's a topic that underpins so much of what we do.
Definitely. And getting it right is crucial for patient outcomes, and let's be honest, for exams like the MRCS too.
So we've got a good handle on the basics, monitoring what goes wrong and how we fix it, resuscitation, maintenance, replacement, all the key bits.
Right. Our mission today is really to unpack all of that, pull out the essentials you need for managing patients effectively, and yes, for acing those exams.
Let's get into it.
Okay, so starting right at the beginning, fluid balance. What exactly are we talking about?
Well, at its simplest, it's about equilibrium, isn't it? The balance between the fluid coming into the body and the fluid going out.
Input versus output.
Exactly.
Mm-hmm.
And maintaining this balance is vital for, well, pretty much every metabolic process. It's core to homeostasis.
And reminds us about the composition. How much fluid are we actually dealing with?
Yeah, it's quite a lot. Around 60% of our body weight is water. And it's not all in one place, obviously.
Right.
Roughly 2/3 is inside the cells, that's intracellular fluid.
Okay.
And the other third is outside the cells, extracellular. That includes plasma, interstitial fluid.
And the constant movement between these compartments is key.
Precisely. Water, electrolytes, they're always moving back and forth, mainly by diffusion and osmosis, all to keep things stable. It's a very dynamic system.
Which brings us to monitoring. Why is it so critical to keep such a close eye on this?
Because imbalances can be really dangerous, fast. Too little fluid, hypovolemia, leads to poor organ perfusion shock, essentially.
That's good.
Not good at all. And too much hypervolemia, well, that can swamp the system, often pointing towards heart or kidney problems.
And it's not just about the volume, is it? The electrolytes get thrown off too.
Exactly. Electrolyte imbalances are a major hazard. Things like potassium shifts can cause serious cardiac arrhythmias, and other imbalances mess up metabolism. Very risky.
So, practically speaking, how do we monitor? What are the go-to methods?
First up is always the clinical examination. You're looking for signs.
Like what?
Signs of dehydration. Are the mucous membranes dry? Check capillary refill time. Is it prolonged, like over 2 seconds? That suggests poor perfusion. Sunken eyes in severe cases.
Okay. And for overload?
You might see edema, perhaps puffy ankles or sacral edema if they're bedbound. A raised JVP jugular venous pressure is another classic sign. Listening for crackles in the lungs, too.
And vitals, what story do they tell?
Oh, vital signs are crucial. In depletion, you'd expect maybe low blood pressure, hypotension, and the body often compensates with a faster heart rate, tachycardia, and maybe faster breathing.
And overload?
Could be high blood pressure, hypertension, maybe a bounding pulse. Tachycardia can happen there, too, actually.
What about urine output? You hear a lot about that.
Hugely important. It's often one of the earliest and most sensitive indicators. We typically want to see more than 0.5 ml per kilo per hour.
So 0.5 milliliter.
Yeah, that's the target. If it drops significantly, that's a real warning sign of potential depletion or kidney issues.
Are there other things, maybe less immediate checks?
Definitely. Daily weights are surprisingly useful. Small changes day to day can show fluid shifts before they become clinically obvious. A sudden gain or loss is a bit of a red flag.
Makes sense. And lab tests?
Labs are essential. We look at urea and creatinine. They often rise in dehydration as the kidneys try to conserve water. Electrolytes, obviously, are vital for spotting and managing those dangerous imbalances.
Sodium, potassium.
Exactly. And hematocrit can sometimes be helpful, too. It might be elevated in dehydration because the blood is more concentrated. Hemoconcentration.
Right. So it's a combination: clinical signs, vitals, urine, weight, labs. You need the whole picture.
You really do. No single thing tells the whole story.
Okay, let's shift gears. What typically causes these imbalances in surgical patients or, general medical patients?
Oh, lots of things can knock it out of whack. Very common causes are simple fluid losses, think diarrhea, vomiting, high output from an NG tube, or surgical drains.
Yeah, it's stuff we see all the time.
All the time. Also, big operations themselves can cause shifts. Blood loss, obviously, but also third spacing, where fluid moves out of the circulation to the tissues.
Ah, yes. Third spacing. Tricky to manage.
It can be. Then you've got underlying conditions. Acute kidney injury is a big one. Diabetes, especially if blood sugar is high, causing lots of urination polyuria.
Right, the osmotic diuresis.
Exactly. And heart failure or chronic kidney disease often lead to fluid retention, so overload.
And sometimes we cause it.
Unfortunately, yes. Iatrogenic causes. Using diuretics too aggressively, maybe, or even just getting maintenance fluids slightly wrong over time. Malnutrition can also play a part, affecting colloid osmotic pressure.
It's a wide net. So let's talk interventions. First, the emergency situation, fluid resuscitation. When do we jump in immediately?
You need resuscitation when there are clear signs of shock or significant hypovolemia. The classic triggers are systolic blood pressure under 100 millimilli Hg,
Okay.
heart rate over 90 beats per minute, cap refill longer than 2 seconds, breathing fast, maybe over 20 breaths a minute, and cold, clammy peripheries.
So those are the alarm bells. What's the first move?
Get fluids in fast. Typically a bolus of 500 milliliters of a crystalloid solution, like Hartmann's or saline, given quickly over about 15 minutes.
500 milliliter stat.
Pretty much.
Right.
And crucially, while you're doing that, you have to figure out why they're shocked and treat the underlying cause. Is it bleeding, sepsis, dehydration?
Right. The bolus buys time but doesn't fix the root problem.
Exactly. And if they're still unstable after that first 500 milliliters, they likely need more, sometimes quite a bit more, potentially over 2 liters. But you reassess constantly. How they respond tells you a lot.
Okay, that's the acute resuscitation. What about less urgent situations? Patients who just can't drink, maybe they're NBM before surgery or have a bowel obstruction, that's maintenance fluids, right?
That's right. Maintenance therapy is for patients who aren't actually depleted now, but can't take fluids orally. So, yeah, preoperative NBM, maybe postoperative ileus where the gut isn't working.
How do we calculate how much they need just to tick over?
The standard guideline is around 25 to 30 milliliters per kilogram of body weight per day.
25-30 millicile kilogay.
Yeah, but there's a more detailed calculation often used, especially for getting the rate right. It's based on weight bands.
Ah, the 105-20 rule.
That's the one. 100 millimeters per kilo per day for the first 10 kilos of body weight.
Okay.
Then 50 milliliters per kilo per day for the next 10 kilos.
Right.
And then 20 milliliters per kilo per day for every kilogram over 20 kilos.
That gives you the total daily volume needed for maintenance.
Correct. It accounts for the fact that metabolic rate and fluid needs aren't perfectly linear with weight.
Got it. That's helpful. Now, the last category, fluid replacement. This sounds like it's for patients who are already behind or losing extra fluid.
Exactly. Replacement is for patients who are stable, not shocked, but definitely dehydrated, or they have ongoing losses that need correcting. Think someone with persistent diarrhea, or maybe slow GI bleeding, like Melina.
So it's correcting a deficit and keeping up with ongoing losses?
Precisely. You calculate their maintenance needs, like we just discussed, but then you have to add extra fluid to cover the estimated deficit and whatever they're currently losing.
And you need to account for anything they are managing to take in.
Yes. Definitely factor in any oral or enteral intake, even fluids given with IV medications. It all counts towards the balance.
And electrolytes become really key here too, I imagine.
Absolutely critical. If you're replacing deficits, especially if there are significant electrolyte abnormalities, you need frequent lab monitoring. Correcting things like sodium or potassium too quickly can be just as dangerous as the imbalance itself.
So it's a careful balancing act, adjusting based on clinical picture and labs.
It really is. Constant reassessment is key for replacement therapy.
This has been a fantastic run-through. We've really hit the core principles of fluid balance, why it matters, how we track it with monitoring,
Covered the common causes that throw things off.
and then walked through the main strategies. That urgent resuscitation, the day-to-day maintenance, and the more nuanced replacement therapy.
Yeah, the fundamentals are all there.
It really underscores how vital careful assessment and a solid understanding are. You absolutely need this for good patient care.
Couldn't agree more. Vigilance and knowing these principles inside out are essential, not just for practice, but as you said, for getting through surgical training and those exams.
Well, thank you for breaking that all down so clearly. Join us next time on MedSimu Surgery Podcast, where we'll tackle another key topic in surgical practice.